Good morning and welcome to Medicine Grand Rounds. I'm really excited to introduce our speaker today, Dr. Timothy Quill. He is a part of the Chair's Distinguished Lecture Series, which is better known as our Dream Speaker Series, where one of our chief residents gets to pick someone that they admire and would like to hear give grand rounds. And Scott Saunders identified Dr. Quill for today. He's a graduate of Amherst and then went to Rochester to receive his MD degree, his internship and residency, and then a combined fellowship as a medicine psychiatry liaison, and then stayed on the faculty, going up through the ranks initially as a senior instructor, clinical assistant professor, up to his current position. He served as director of the Palliative Care Program and division head of their Division of Palliative Care from 2008 to 2015. He's currently the Gosnell Distinguished Professor of Medicine, Psychiatry, Medical Humanities and Nursing in the Department of Medicine, the Palliative Care Division, and is acting director of the Schyve Center for Bioethics at the University of Rochester Medical Center. He has research interests that include end-of-life decision-making, cost and quality implications of palliative care, and the doctor-patient relationship, and has been funded throughout his career through a number of foundation grants, as well as the NIH, the NCI, the PCORI, as well as HRSA. He's published 133 original articles. I always think it's interesting to see where people start. And his first paper ever was in the Annals on Partnerships in Patient Care, and most recently a paper published just this year in the Journal of Medical Ethics on the Dutch practice of euthanasia and assisted suicide. He's also published 8 books and contributed 25 chapters and reviews. He's an active educator for medical students, house staff, fellows, and in faculty development, and is a good citizen nationally, serving in a number of capacities with national organizations, including serving as on the editorial board of the Journal of Palliative Medicine, and service with the ACP, the Visiting Nurse Association, the Death and Dignity National Center, and especially the American Academy of Hospice and Palliative Medicine, where he is a past board president. He's received a number of honors along the way, including teaching awards, as well as the ASC and ASIM William Menninger Memorial Award for Distinguished Contributions in the Science of Mental Health, and most recently in 2015, the Association of Specialty Professors presented him with the Nielsen Distinguished Professor Award. I counted over 30 visiting professorships and lectureships in the last 3 years, but among those I never saw a dream speaker invitation, so there's at least that first in his illustrious career. Today we're really fortunate to have him present grand rounds entitled Discussing Prognosis with Patients and Families, Balancing Honesty, Compassion, and Hope. Please join me in welcoming Dr. Quill.
Thank you very much. It's a real pleasure to be with you today. I want to thank Dr. Page and the Chiefs for entertaining me in such a fun way last night. And I also want to thank Madeline Alt for doing all the arrangements with all the changes that we have made. This is a little bit like bringing coals to Newcastle because we have Toby and Jim here as these luminaries in palliative care. All of this, what I'm going to be talking about today, is a little bit broader than palliative care. These are skills that all good doctors should know how to do, and probably things that people have not been taught how to do. So how many of you have been taught about how to talk about prognosis? Okay, so that's a much higher percentage, and it's probably as a result of the work that you do here. So I'll give you my take on this, and then we'll see where this goes. I'm also going to make you work a little bit, so it's not going to be listening to me the whole time. So you can steel yourself a little bit for that. Okay, so I do have no significant conflicts of interest in this zone to disclose, unfortunately. we're going to talk about barriers and pitfalls, briefly review the state of the art and science about discussing prognosis, and then I'm going to present a strategy for discussing prognosis, and then we'll practice that strategy. So again, you may have been taught other strategies. This is just one more strategy to put in your tool belt. So again, what are the sources for this information? There's a lot of systematic reviews. There's been an NCI-sponsored review of patient-centered communication in cancer care. Up to date actually has a number of chapters that are focused on these subjects for generalists in particular. And then there have been a fair number of studies and expert opinion. So again, there's a lot of evidence that patients don't really understand their prognosis. So a third of patients with metastatic disease believe it was localized. A third of those receiving palliative treatment believed it was curative in intent. Most patients, when they're asked to estimate their own prognosis, overestimate it. And if you overestimate your prognosis, you're going to tend to choose treatment that is probably more aggressive than what you should, that you're not that likely to benefit from. So again, about 80% of people who have advanced cancer are told their disease is incurable, but around half are told about their prognosis, and quality of life is only addressed about a third of the time. And again, only about a third of patients are given the full range of options when they're looking at diseases for which we don't have very good treatment. So again, there are data that information does not increase anxiety, so if the reason is that we're protecting patients to make them not as anxious, that's probably not true. So again, physician barriers, most have not been trained. Again, you live in a place that pays attention to these issues, but most doctors don't. And we have more discomfort as prognosis worsens. So we're more willing to talk about it when it's positive, less willing as it gets worse, because we don't want to upset people. We fear depriving them of hope. And we're much more comfortable about talking about disease and treatment than we are about prognosis. We'd like to emphasize the positive. We want to be upbeat with our patients. I've talked to a number of oncology fellows, and they fear that people will go to other places if they talk about prognosis in a real way. So again, there's a culture in oncology that maybe we shouldn't talk about prognosis because people won't see our place. Our place won't be seen as a place of hope. People favor truth-telling in general, but feel uncomfortable sharing dire prognoses, and again. So if we look at predicted versus actual survival, this is in hospice patients, you can see that about two-thirds overestimated the actual prognosis compared to what really happened. So even in hospice and palliative care, we tend to err on the optimistic side. And we can explore a little, what's wrong with that? Is there anything wrong with that? And maybe there isn't too much wrong with it, but maybe there is. So it's correlated but not calibrated. So we tend to be a little bit on the optimistic side whenever we're giving a prognosis. We like the horizon. We like to make that more like the mean. And the closer we are with patients, the less likely we are to be direct and honest with them. So there is some countertransference about the people that we care about. We like to be kind to them. And we could think about whether that's being kind or not. What do patients want? They want information about prognosis and options. They want realism with compassion, so they don't want to be bludgeoned with prognostic information. They want hope, and where's hope going to come from as prognosis worsens? And they want lessening of uncertainty. And if we're looking at probabilities, there's going to be a lot of uncertainty. So again, a lot of these things may not be things we can deliver. But they are ambivalent and inconsistent. So again, as prognosis gets worse, people tend to want to know less about it. So if they're asked whether they want to know less. Information needs seem to change as death becomes more imminent. There's tremendous amount of individual and cultural variation. So there are cultures in which talking about this stuff is not what you're supposed to do. So you can talk to the family maybe, but you're not supposed to talk to the patient because that would have a bad effect on them spiritually, potentially. People get information from also lots of different places. So if in Wisconsin you're a little realistic and a little bit dour about this or dour about this, they may want to go down to the other meccas that are around the area because they're more upbeat, and that's a fear that people have. Should family members be present for this discussion? Again, most patients, when asked if they want family members present, want them to be present. They want control over which family members are present and what is discussed. And there are problems when families are told first. Families sometimes don't want to then tell the patient, don't tell mom about this because it would kill her, that kind of thing. And there's a lot of cultural variation. So there are cultures in which families are told and patients are not told. And we have to be students and be respectful of those cultures. Outcomes associated with these discussions increase. If you have an open discussion about prognosis, people tend to be satisfied. It tends to decrease depression and anxiety, and it has a mixed effect on hope. So it doesn't make people feel more hopeful. They may get more realistic. Deceit and withholding prognostic information decreases satisfaction, increases anxiety and depression and distrust, and people tend to choose overly aggressive treatment. So just a few words about how to estimate prognosis. And again, with up-to-date and a lot of the databases that are out there, you can really get a good read on prognosis for populations. So again, in cancer care, the specific diagnosis and extent of spread will give you a good indication. And in heart failure and other diseases, there are similar databases. So you go to manuals, textbooks. There are sometimes randomized controlled trials. And you can also talk to the experts in your group, the people who see those patients the most within your organization. There are also other factors that influence prognosis. So within the world of the average patient with your disease, people with a high performance status will have a better prognosis in that group than those with a low performance status. And those who are much more symptomatic acutely will have a worse prognosis within that general group. So again, what their individual status is can make a difference within the overall population-based prognostic data. So there will also be other factors, whether they're taking disease-driven therapy, whether it's likely to work, how harsh it is, what are the odds, what's the toxicity, and whether they're getting palliative treatment at the same time. And again, you all know that palliative treatment is not incompatible with the most aggressive treatment. In point of fact, there are data that people who get palliative treatment from the get-go, sometimes with at least some disease categories, will live longer than those who don't get it from the get-go. So these treatments are not mutually exclusive. If you're trying to figure out the prognosis, and it's a little hard to come by, you can review the data, the medical literature, figure out if more testing is going to help you know more. You can get opinions from experts, discussion from uninvolved colleagues, and in general, you want to try with the modern world where there are people with each disease, each organ has a specialist involved. It's good to have that group sit down together and figure out that we're in agreement about what the prognosis is before you're going to talk to the patient about it, and figure out who out of the group knows the patient and family best to really have a frank conversation with them about this. So again, this is a little bit complex in a person with multi-organ system difficulties. So now we're going to get down to the practicalities of this process, sort of the do's and don'ts potentially. And this again will move more toward expert opinion than data. There's not a huge amount of data that this is based on, although there is a consensus amongst many people who are doing this for a living. So there are some basic communication skills that we really pay attention to the start of these encounters. We use ask, tell, ask, which you all are probably familiar with. Responding to emotion, tell me more, and involving family members. So again, getting prepared for these conversations is very key. So ensure that you understand the patient's clinical situation and your role. If you're a consultant, are you the one that's supposed to be talking about this or not? Where does the primary care physician fit into this mix? Be clear about the agenda for the particular meeting. Is this a daily update or is this a big meeting to discuss some major decisions? So we're going to adjust the setting and invitees to the agenda. If we're having a major decision meeting, that's one where you're going to allow some time. You're going to try to have the key players there and think through as a group before you go into that meeting what you're going to say, who's going to take the lead. So some triggers for prognostic discussions. I will tell you the bottom trigger is the most common trigger for prognosis discussions, right? That we put it off until the patient's actively dying, and then we have that discussion. But in point of fact, new diagnosis of a serious disease, if a major decision that has an uncertain outcome is in the horizon. Sometimes people will ask us what's the prognosis. When they request treatments that aren't consistent with good medical care, it seems like overly aggressive or underly aggressive. And again, the surprise question. Think about the patients that you're rounding on today. How many of them would you be surprised if they died in the next 6 to 12 months? If you would not be surprised, would they be surprised? Or would their family be surprised? And again, if you would not be surprised and they would be surprised, that's somebody that you might consider having a prognosis discussion with. So how do you get prepared? We make sure the facts are correct. We estimate the average survival in ballpark range. We're going to invite key people who should be there and protect time and attend to privacy and think through what we're going to say in advance. And then using ask, tell, ask. How many are familiar with ask, tell, ask? Okay, the same ones who raised their hand before. So what's ask, tell, ask? I ask if they want to talk about prognosis. And if they do want to talk about prognosis, we're going to ask what they already know and where they've gotten that information. So if they want to know, then we're going to tell. We're going to give information in small amounts. We're going to build on what they already know using simple and straightforward language. And then we're going to ask them to repeat what was said to make sure that they heard it correctly, make sure they're on the same page, and then we're going to ask if they want to hear more. What's the biggest mistake we make with ask, tell, ask as doctors? What? Skip the first ask. That's a big one. Skip the second ask. Yeah, skip the second ask. And we talk too much, right? We talk too much. We tell too much. So once we have permission, we have so much information that we want to impart. It's a very caring thing to do, and it's usually perceived to be caring. But usually people, if they're getting new bad news, their ability to receive information after the first little bits is not very good. So again, they don't. It's not necessarily a horrible thing to do, but it's not very efficient. So give a little bit, make sure they heard it. Do you want to hear more now, or would you rather hear it later? And then you repeat the cycle over and over again. So we're going to give a ballpark, or you can use either the median amount or the average person will live, kind of the middle of the normal curve, or what I like to do is the sort of middle part of the normal curve, the range. It could be 80-20 or 90-10. We're going to put that in days to weeks, weeks to a few months. Always acknowledge exceptions in both directions. So a relatively small percentage will live longer. We're going to do everything we can to put you in that group. And then make yourself say that could be shorter. Because even those of us who work in palliative care, we tend to shift that normal curve in an optimistic direction. So if you don't do the could be shorter, people often feel unprepared. So again, some caveats to ask, tell, ask. Physicians tend to tell too much information at once. So if you're talking too much, stop and ask what has been heard. If the patient seems overwhelmed with emotion, telling further information is not going to be processed. So then you're going to have to shift to emotion management strategies. So how do you respond to emotion? If the visit has been all questions, and they've asked questions, then you're going to suggest when they go home they may have a strong emotional response in the future, and if they want to explore those emotions later with you, then you can open the door to that. So whatever hasn't been talked about, you open the door to. So the ballpark with exception, it's impossible to predict for any individual with certainty, but the average person with your illness will live a few weeks to a few months. Treatment, if it works, might extend that time a month or two. It could be longer, and we'll do everything in our power to put you in that group. Unfortunately, it could also be shorter, so we might want to get prepared in case you're in that group. That's sort of the strategy that I'm suggesting. Now, there are framing issues with this. So you can talk about the odds of dying or the odds of surviving. So if somebody has a 50% survival rate, you're going to live 50%, you have a 50% chance of living 6 months. What's the downside of that? What is it? Right, half of you are going to be dead in 6 months. It sounds very different than 50% survival, doesn't it? And yet to make a decision, you're going to need to understand both sides of that. So again, these ranges, 75% will be allowed for 3 months, 25% for 9 months means that also 25% will die in the first 3 months, and 75% will be dead by 9 months. Patients will make different decisions, populations of patients will make different decisions depending on whether the odds are presented in terms of survival or death. And clearly you need to understand both dimensions of that to make an informed decision. So responding to emotion, again, I know the same hands will go up that you've been trained to respond to emotions. And it is the reason I will always come back to this, even in places, even in meccas, is that we don't do it very much. We're much more comfortable with information than we are with emotion. And these basic skills are very easy to teach. You can be a dried up prune. I can be burned out, and I can do the basics of these skills. And in point of fact, if I am burned out and I start doing the basis of these skills, I sometimes don't feel as burned out, right? I start to feel some emotion. So knowing these skills is very useful. So I'll give you just, this is another example. So you're seeing somebody and they start to cry as you tell these things, and we can acknowledge. If you do these things, people think you're so freaking sensitive, and you don't have to be all that sensitive. You know, you just say, "You seem sad." You know, this is not rocket science here. You seem upset. You seem angry. And, you know, we have this tremendous power as doctors to help people feel more normal. So anyone in your shoes would be frightened. I would feel frightened in your shoes. Anybody would feel frightened. And if sometimes I'm giving somebody the diagnosis of hypertension or you know, something relatively minor in my eyes, and they are devastated by this, and I don't get it. So what do I do then? I say, tell me more about that. Tell me what's bugging you about this. Tell me why this is affecting you. Tell me more. Tell me more. And eventually they tell me the story. You know, well, my dad had hypertension, and shortly thereafter he had a big stroke. I'm terrified about a stroke. And then I get it. Then I get why hypertension is devastating to this person, and then I can potentially empathize. Now, you only do empathy if you really feel it. Like faking empathy, bad idea, right? So if you can imagine what the patient is feeling, and then you put some words on it, then that is a very good thing to do if you feel it. If you don't feel it, the other skills are plenty. They're good enough. Isn't there a good enough thing recently in the news? Anyway. And then support and non-abandonment, very key in today's world, particularly if you're thinking about stopping aggressive treatment. Who in the world is going to take care of me if I stop aggressive treatment? Many people, I believe, continue aggressive treatment because they don't want to lose their doctors who've been caring about them. So who's going to care for them? Is it going to be the oncologist? Is it going to be the palliative care doctor? Is it going to go back to the primary care doctor? Clearly it has to be figured out. And then if I've been working with them extensively, how are we going to do? What's going to happen with our relationship? Am I dropping out or not? So this is very key in the modern world. I want you also to experiment with wish statements. I love wish statements. How many are familiar with wish statements? Same group. Great. All right. This is great. So when you have bad news for somebody, I always wish I had better news. I always wish medicine was more powerful than it was. I wish we had more options than we do. I wish things had turned out better. I will tell you, and I do genuinely, I'm not faking this, I really do wish those things. And yet wish statements do this amazing thing because they reframe what is hoped for as a wish. It acknowledges that it is not likely to happen, although it could happen. And it's an empathic statement. It really identifies what the patient is hoping for as well and puts the hope in a more realistic frame. Again, it needs to be followed by emotion management language and planning for what comes next. But I would encourage you, those of you who haven't used these statements, to experiment with them. If you have a recommendation, don't withhold it. I will tell you this is a huge peeve of mine with the modern era, with patient autonomy movement, that patients are given options from which to choose. Right? You could do this, you could do that, there's others, there's the odds of that. And they are not told what we really think is the best course for them. Sometimes we don't even figure out what we think is the best course. We think about options. So I won't ask for a show of hands about whether you all give recommendations, but if you don't, I want to encourage you to think about beginning to do so. And the reason why people don't is because there's been this huge reaction from paternalism, right? Paternalism where the doctor knows best and the doctor's in control. And in point of fact, people are desperate for our ideas and our recommendations. So given what I know about your disease and what I know about you as a person, those are the two things that go into a recommendation: your medical knowledge and your knowledge about their views and values as a person. Would you like to know what I recommend? So we can do the ask, tell, ask thing here. And if yes, then you're going to give the recommendations and reasoning. If no, you're going to ask, tell me more about that. Why don't you want to know? Some people really don't want, they feel overly controlled by recommendations, and I think that's possible. But usually when I encounter those folks, I will say, look, it's still your choice, but and if you don't want to hear my recommendations, I won't give them to you. But almost always people will want to hear them. And then we'll do the ask. If you have questions about that, repeat the cycle as needed. So we're going to reinforce that we're willing to care for the patient no matter what choice they make. If they make a choice against the recommendations, if they make a decision that's other than what you recommend, we're going to try to make sure that we understand their thinking about that. We're going to listen carefully to their reasoning, and if they seem to be missing a key point, we're going to try to fill in that key point. And then, again, move forward. Some pitfalls in discussing prognosis. Starting too late, probably the most common one, that we withhold it until we're moving toward hospice time. We expect too much too soon, so when we open the door, would you like to talk about this? We're looking for people to make decisions, and they're just kind of reeling with this first understanding of where they are in the disease trajectory. Giving too much information in one sitting, ignoring strong emotion, and biasing the conversation toward the desired outcome. And again, I may be as guilty as anyone else of trying to do that based on my view of what's the right thing to do. But I think even bigger than that is not giving a recommendation. So I'm going to pause and see if there's any questions, because that's sort of the information background. I want to see if there are questions and comments about the process that I've been describing. Question? Yes?
You talk about feeling with emotion. What is your technique when there is tears and sobbing?
So what's my, dealing with emotion, what's my technique when there's tears and sobbing? Probably just being with them, and I sometimes put words. I can see that you're devastated. Silence. If it feels appropriate, again, I'm a toucher, a hugger. If people feel, I'll test the water. If I do that and they go like that, I think, oh, that wasn't a good idea. But most people, and just give it some time. And if it stays and stays and stays, I will say, we're clearly going to have to deal with this. Is there anybody I can call? The information giving is not going to happen at this point, right? You're going to have to work through this emotion before it occurs. Yeah. Other questions or comments so far? Yeah.
A big challenge is providing options that are contrasting, and one option being relatively well tolerated, non-curative, versus another option that would be horribly toxic with a very small chance of cure.
Right.
And so, these survival curves are very different. Any suggestions on conveying that type of information to allow people to make informed choices?
So I'll try to repeat that and make sure if I get it right. So some of the choices are really hard. So the way I would frame it, sometimes there's easy treatment that has a certain probability of working, and there's a working a little bit. And let's say there's very harsh treatment that has a smaller probability but working longer. Those kinds of where the differences are pretty significant, right? Okay, so one option there's a chance of cure, and the other option is more palliative treatment. And again, I think those are tough. I think you have to think through, first of all, how realistic those options are for this particular patient. You as the doctor have to think that through. So if it really is, you're looking at options, and you really think from what you know about them as a person that one of those options is better, I think helping them make that decision, because these are really hard decisions for us to make, much less for them to make. If it really is, they're really different, and they really depend on that person. I think you really have to put both those options out there and say, I'm not sure what's the right way of these two, so we're going to have to work this out together and talk it through. And I'd like to have people, if the disease allows that, to take some time to think that over. So let's both take a week, think it over, kind of talk it over, read about it, and then make a decision after that. Some of the decisions we ask people to choose between are very hard, right? Yeah. Yes. She's talking about, I'll try to rephrase this, just how chaotic our system is, and how difficult it is to have a sustained relationship with people, so you have the same decision-making process going on at the same time. So if you're a primary care doc at home, you have somebody on hospice, they have a problem, they go to the ED, and they get into very aggressive treatment. Now again, part of this is people on hospice, if they break a leg, they often should have that leg fixed, right? Because if it's a quality of life issue. But if we're going to shift then the whole plan of care toward more aggressive treatment, that's a huge change to make. And how to, there may be sometimes that is worth considering, but certainly we ought to be much more mindful, those of us who work in hospitals, that we are changing a whole course of action that's really been decided upon, and how undermining that is potentially. So I don't have an easy answer for that, other than certainly calling the primary care doc, whoever is the primary treating doc, in always including that person in these discussions, because a primary treating doc is a rare bird right now, and we really need to respect them and honor them and include them, even if they aren't coming to the hospital really for major decisions. So I don't have a simple answer for you. Yeah. Yes. Yeah.
And I'm really appreciative of this information, because it's appreciated when this information is coming to you. But as an emerging psychologist, I think that consulting psychology sometimes for some basic attending skills, some basic listening skills can be very helpful. I think empathy is something that you can find in anybody if you're just looking for that nugget of what you actually like with them. So I think that even just saying like it's good enough,
Yeah. So empathy can, I think it can be learned, and it certainly can be reinforced, and you can bring it out. And I do think involving our colleagues from psychology, both to help us out and also help us out with difficult cases, is really an important piece of the puzzle. We sort of, those of us in medicine, by and large, learn this by the seat of our pants, by and large, and that may not be always the best way to learn it. Whereas you guys are more systematically taught how to do these things and how to respond. And I really believe these things are teachable, that you can learn them, you can deepen your own skill set. Yeah. Yes?
You're dealing with patients that may have had a second opinion, sometimes from a for-profit cancer treatment center.
Yeah.
That gives them a much rosier prognosis than your home physician or being yourself at treating them. And you just simply help them collectively.
So what do you do with second opinions that are way more optimistic than what you're reading of the literature? So certainly if people want to get second opinions, I encourage them to get them. I try to steer them to places that I think are really good places to get second opinions, and steer them away from other places that may be overly hopeful or, in my eyes, a little bit profiteering. But if they go there, I just ask them, come back after you've seen them and let's talk it through and try to make sure that we're more or less on the same page. It's a wild west out there a little bit, particularly if you have money as a patient. So poor people aren't invited to go to those places, and that's a whole problem in itself, which we won't get into. All right, I'm going to shift gears to our case, because that's where I'm going to make you all work a little bit. So, and of course, it's not going to be an easy case, right? It's going to be, the patient is this young man. He was a young father at the time of his diagnosis, 25 years old. He had an uncle with melanoma. He had an ulcerated mole on his lower back that he observed for about a year before getting help, and it ended up being a malignant melanoma. He had a sentinel node that was positive, so he was stage 3B. And again, we're not going to spend too much time on the medical details. This is going to be on the communication issues. So look at the survival curves at stage 3B. He's got about, let's say, an 80% chance or so of surviving 2 years, and there's a long tail on this. So he may go a long time without treatment and survive. So again, the one year survival, 92%, the 1 year death rate, 8%. So again, we're getting back, one sounds mighty good, and one sounds not so good if you're 25, right? 5 year survival, 60, 5 year death rate, 40%, 10 year survival, 25, and 10 year death rate, 75%. So at the time he was diagnosed, interferon was the main treatment. Interferon, those of you who are old timers know interferon stinks. It's a hard treatment. It makes a little bit of difference not in terms of cure, but in terms of survival. But if you were in his shoes, you would probably all choose interferon, right? Because you're desperate to try anything. So, how long do you think I have, and what are my odds? This is what he wants to know. He really wants to know these things. He's a very anxious man, but he really wants to know these things because he's got his young family. So, what I'm going to ask you to do is to introduce yourself to the person next to you. One's going to be the doctor and one's going to be the patient. And you already have a relationship. You've already done all the good communication skills that you've learned here in Wisconsin. And you're going right to the question, how long do you think I have? And I want you to experiment with just using the language of giving a ballpark with exceptions in both directions and responding to any emotion that you have. So this will be a very quick role play. I know everybody loves role play, so just do it. Okay, let's just stop in the middle of your sentence and we'll break out of the role. And let's just hear from a couple of the patients. What's it like, even in a role play, to begin to receive information like this? Any patients have anything to say? Those who are playing patients, yeah.
Kind of a funny combination of, when you're talking in terms of years and thinking of myself having little kids would be like, well, no, I need to know right now because I need to make plans and I'm anxious if you're giving me this, vague, maybe 2 years, maybe 10 years, maybe less.
It wasn't that vague, was it?
But the information itself is inherently vague in a certain way, right? It's like it's a big range to try to take in. Other patients, just a couple quick. What?
No, I was going to say the position.
Hold that thought. I'll call on you first. Yeah.
You're needing a 25% chance that you're going to live for 10 years if you're 25 years old and you're starting to drum out the hospital.
Okay, so the 25%, we're pretty excited about a 25% chance somebody's going to live 10 years. But hearing that as a 25-year-old, it's devastating, right? Yeah. Yes.
I think a lot depends on the patient's predisposition. Some people tend to be naturally optimistic, and some people tend to be naturally pessimistic. So I don't think all people are the same.
True.
What the response to the news depends on what their predisposition was prior to getting it.
There is truth to that. The people's predisposition will determine to some degree how they're going to respond to that. But even a super optimistic person hearing this for the first time, I think, is going to be a little bit shaken, right? Right? Yeah.
Even though I'm looking at palliative care, it was surprising the reaction of fear
Yeah.
I had. I just was surprised I felt fear.
You felt fear. She was surprised. She works in palliative care. She was surprised how much fear she felt. And it's surprising that even those of us in palliative care would be surprised by that, right? Because playing the role of patient is hard even for us to imagine what this would be like, even though it's really hard. How about the docs? What was it like? Yeah.
One of the things that I think is really important is to remember a lot of people have numeracy problems with percents and numbers.
Yeah.
And converting these percents into something that's more reasonable for any person to understand, I think is really important.
Yeah, so it's what do you do with people who have problems with numeracy? And again, so you can talk about the average amount and think about whether that would be the median amount, which would be somewhere around 8 years. Would that be more scary or less scary? Could somebody understand that? But people who have trouble with numeracy, you have to figure out different ways to get at this. And there was, yeah.
I think part of this is being the oncologist who has to frame for how I do this and
Yeah.
feeling, the last thing when the oncologist saying why I'm not banging my patient with this right now. I think the thing is particularly, I in some ways think giving numbers like this to someone whose median survival is over 5 years and rapidly evolving field, I don't know if that's useful information to give them. And so, for example, people who have diseases like myeloma or melanoma where, they're going to get a certain time, they're likely to get a certain amount of time. And I think it's important for them to know the 2-year number because they do need to plan for that. But quite honestly, if they're at 5, things could be completely different 5 years from now than they are right now.
Right.
So I think to some extent you have to, as an oncologist, I can frame these in relation to the decisions that they're going to reflect. So if the decision is, do you get your fear on, I think the question is, well, what does that affect my 2-year survival and things? But, with a young person, with a young family, the presumption is that you get them through that and that most reasonable people are going to head that direction. So I think that's an important part of how I frame these conversations with people who are here.
Right. And this man would have challenged you on that, by the way, because he really wanted to know the other end of this. And you probably would have gone through your thing, and then if he really pushed you on it, you would have gone to the other tail. Okay. Yes.
I've unfortunately had a lot of these discussions with patients, and if I'm listening to you talk, it suddenly hits me. Median survival doesn't help you there.
Right.
What do you do with that? I'm either really in the hurt locker or I've got some hope here. I don't think it helps you as much as
I also have found giving the usual range to be more helpful than the median survival, but always making myself do the outliers on both ends. And there's importance on both the outliers, right? One is the hope outlier and the unforeseen, wonderful developments that might occur, and the other is that, boy, it could be really shorter, and this man has to do some preparation in case it is that. Yeah.
When you talked about fear, but when we were interacting, I think guilt was a huge thing, right? So why didn't I go get that checked? I knew my father had melanoma.
Right.
How do you deal with the guilt?
Right.
What could have been done?
Yeah, so the guilt of having sat on this for a long time was very big with this man, and that's going to be that's not going to be dealt with in a 15-minute visit or a 30-minute visit where we're trying to make decisions, but it's going to be there and needs attention. So I'm going to move us forward with the case. So 2.5 years later, he presented with a right frontal headache. The MRI showed a right occipital enhancing mass. He was presented to our multidisciplinary tumor board, and treatment options were given, including stereotactic surgery for this, and we set up a family meeting to develop a treatment plan. So this is just a picture of his lesion in his occipital area, and now his curve is radically different, right? You can see the 6 month, and he's in the brain, so he's in the green group. 6 month survival chance is low, and the long-term survival is extremely low. Now he has a good performance status, though. He's otherwise, other than having a little bit of cognitive difficulties, his performance status is normal. So that puts him a little bit more in an optimistic zone. Again, these are small increments, but again, in his shoes, they make a big difference. Again, I won't show that. So what is his prognosis? Median survival is now 7 months, 75% chance he'll live 4 months, 25% he'll live for 12 months. He has a single brain met, which is a positive prognostic factor, no other visceral symptoms. And aggressive treatment here is associated with better outcomes. So again, we wanted to treat him aggressively. There's a new wild card on the scene as this happens. Also, immunotherapy has just entered the scene. And there are promising early studies, even for patients with advanced disease. So that tail is potentially a much different tail if he gets a big response. So the communication challenge here is how to balance optimism and realism. So what does this mean in terms of my future? And what I'm going to ask whoever was the patient last time is now the doctor. Whoever's the doctor last time is the patient. And just go right to the what do you think is my prognosis now? So just do it for a couple minutes. Go. Okay, let's pull back together. And here once again from the patients first. What's it like to hear this stuff even in a role play from some of the patients? Any comments from the patients? Yeah. What's confusing? Being a patient is confusing. What's confusing about it? Yeah. So it feels sort of overwhelming and diffuse. And how does this? I've had patients. What does it say? What did it felt like they weren't talking about me. You know, it doesn't. It just doesn't compute even. Hard to take in. Yeah. Other comments from the patients? Yeah.
Listening to something like that without a family member present or an advocate present would just go
Yeah. So just in thinking about that and setting it up, although sometimes saying without having a family member present to hear it with you, it would be, you'd go ballistic, or transcochlear is the word. And I think that's very true. Although sometimes you have to give this information because there's nobody there with somebody, or people don't have somebody. But ideally, you have somebody there. And again, there's a whole business about when you're having somebody come in for bad news and you get them on the phone and say, I want you to come in. I really don't want to talk to you about this on the phone. Well, what is, what are you saying here, doc? But there is a difference between hearing it and actually hearing it. And I think ideally you have family members there to hear it, so you have an extra set of ears. Yeah.
I would think my MRI would be kind of similar. Huge macroadenoma. But, I'm looking at the MRI with this big tumor, right below my brain. I don't think I was listening. I looked at that and said, I'm dead.
Yeah.
I mean, you look at that big white spot.
Yeah.
Therefore, your brain should be.
Yeah. So seeing things like that or hearing things like that, many of our brains go on to tilt. So taking a lot of information in is not going to occur, right? Yeah.
I'm wondering about the value the patients of using the term 25% versus saying probably won't be alive in a year from now.
I think that would be getting at one tail. Yeah. I would say they're going to be really surprised if they're not alive in 3 weeks. If you just tell them that. So again, there is something about doing both of the tails that is very, I think, important for people to know in this circumstance.
Well, I guess the point was, maybe I would say probably will be alive in 6 months, but 18 months, might not be, probably won't be. I'm just wondering about the value of using descriptive terms rather than the number.
Yeah. Yeah, again, I think someone said some people are very number-oriented, some people are more conceptual-oriented, and again, knowing where your patient is in this process. I'm very number-oriented, so I have to maybe guard against that a little bit, but I do think sometimes the number puts something, it makes it a little bit more concrete. How about, go ahead, one more. Yeah.
What do you think about using visual aids to try to convey some of the things that really happen?
Yeah, I've seen those things. I use them zero, so that probably says what I think. But I know people who use them. So I think if you're oriented in that way, either as if it helps you as a doctor describe things, I think having those things in your pocket. I think anything that makes you feel like you can get at this in a way that can help people understand can be helpful. Yeah.
My suggestion really would be to ask the patient, because some patients respond to visuals, some to words, some to numbers. Even the words can be very confusing. If we say not very likely, that can be a range from 2% to 80% chance of survival.
Right. How about the docs? What was it like to give this information as a doc? Just a word from a couple of the docs. Yeah.
One of the things that you mentioned earlier was that a problem with how we give news is that we sometimes talk too much. I think it's so nerve-wracking to be giving people this information. That's the first thing that my brain went to, just talk more.
Right. That would be a very doctorly thing to do, But it's generally perceived to be comforting. It's generally perceived to be caring. So it's not a harmful thing to do. But you shouldn't have the illusion that the information that you're talking is going to penetrate a person who's in tilt. Another word from the docs? Any of the docs? Yes. Yeah, so it's really sad, and really sad for the patient, and sad for us. Any of you criers in the room? Any of you docs criers? I'm a crier. So I talk about doing these things wet versus dry, you know. So things like this with somebody I care about, I'm going to be wet. It's just the way it is, and I don't care anymore. You know, and people think I'm super empathic because it's my empathy expressing. So those of you who are wet, as long as you're not bawling. I mean, again, if you're bawling, that's too much, right? But if you're a little wet, it's totally fine, and it's just an expression of how hard this is, right? And then also when you, like with this case, I would do this, and then I would go and talk to my colleagues about how freaking hard this work is sometimes, right? And just to say, wow, this is really, even after all these years, I can still tap into that a little bit, how hard this was. Yeah. So we're in the home stretch here. So I'm just going to go to the, so he was treated with radiosurgery, whole brain radiation, return of headaches after 6 months, more stereotactic surgery, immunotherapy seemed to be working on the other parts of his body, but not his brain. Eventually he reached a point where there were no other options to treat his brain, 4 years after his original diagnosis, and 15 months after his initial diagnosis of brain mets. So he was on the short end of his overall diagnosis, but once he had brain mets, he was on the longer end of the spectrum. He was transitioned to hospice care, still wanted any easy treatments that would help him live longer. Again, we could talk about now, as he came into the hospital with brain mets and back mets, his median survival was 3 months, 10 days to 2 months, could be longer, could be shorter, which we won't do. But the family needed to know how long this was likely to be, so we're in the same conversation and trying to help them understand what ballpark we're in. So again, a couple words in conclusion, and then we'll take 1 or 2 questions. Prognostication requires an analysis of studies, individual factors, expert opinion. Physicians tend to be overly optimistic about prognosis as it worsens. The approach to telling patients and families about prognosis needs to be individualized. Use the ask, tell, ask, guided by patient's preference for information or not, and then the ballpark with outliers in both directions, and making a clear short-term plan. So let me take a couple of questions, and then we'll stop. Thank you. Yes.
Do you have any tips or common pitfalls you see with dealing with the patient who immediately gets really angry? You feel almost like
Yeah, so what do you do with a patient who gets really angry? And I think I struggle with that. First of all, you have to say, how angry are they? Is it safe or versus not safe? You know, I might have somebody, if I anticipate that's going to be that way, I'm going to have somebody in with me. I don't like being intimidated at all, and I don't like feeling unsafe, so I will create safety. But if it is, you know, if you scratch anger, what are you likely to find? Fear and tears, right? And if you scratch fear and tears, what are you likely to find? Some anger. So again, I can, you know, some anger. Tell me more about that. If I'm feeling secure with the person, I will get into it. And almost always tell me what's the scariest. Tell me what makes you the most angry about this. And yeah, I really get it. And it'll often be followed by tears. So again, it's really if I feel secure that I'm not threatened, using these same techniques to tell me more about that, help me understand it. And then once I understand it, we're able to join around that. If I'm threatened, I'll get other people around.
We're going to have to close there. I want to present you with this plaque signed by our own chief residents, acknowledging our appreciation for your serving as visiting professor and giving an outstanding grand rounds. Thank you.
Thank you. Thanks, guys.